excited to be welcoming you to the Nous Melbourne office, and alongside VHA, very excited to be hosting today's event on public health. Is an ounce of prevention worth a pound of cure? I can't remember who came up with that title, but well done. I think it was someone. And it's a very topical session today. We're under extreme financial pressures, not only as a society, but government. We know that turning the sod on TV for a new hospital is always more appealing to viewers and voters and politicians. Yet, we also know that prevention is always better than a cure. So all these things come together and present a lot of challenges. However, there's also a lot of opportunities. And I think Helen just said there's a lot of will in this room. Is there a way? Let's hear from the panel. Are we all swimming in the right direction? Maybe, maybe not. But also let's think outside the box today. Let's also think, do we need to get out of the pool and think about public health differently? I work in the health sector. I work with hospitals, health services, state, federal government, medical research, higher ed, and they all say the same thing. Paul, we need to do health differently. Enough band-aids. Let's look at the gaping wound and let's look at healthcare differently. We can't keep on doing the same thing. Are we investing in the right area? Are we thinking about the patient? Are we putting the patient at the centre? And as Helen said today, we're going to also make you work. You'll see handouts and worksheets on your tables. We don't want you to just be provoked by the panel. We don't want you to just listen. We also want you to give us your ideas, because in fact, after the event, we'll be putting a lot of these ideas down on paper in an insights summary that you can then share. They'll be action-oriented, they'll be pragmatic, and we want to get your best ideas and put them forward. And a little bit about me, I'm a medical practitioner by background. That's how I met Sandra a long time ago. We were med students who thought we were going to save the world. And I think Sandra's probably a little bit closer to that than I am. And after my clinical career, I spent about 11 years in hospital management, a lot of familiar faces in the room, collaborated with Anna and Rachel from Deakin, also was in the same trench with Nadia and CoHealth during COVID, and many others in this room. We've all been through it, and it's interesting to see a lot of the same faces in that battle for better health. And not just better health, but better well-being and a better society. Because we all know health, and I think quoting Sandro, 80% of health, if you take away genetics, is actually not about hospitals. It's about the social determinants. So that's the challenge, but again, there's lots of opportunities. Like Helen, I want to acknowledge country. We're on Wurundjeri land in Naarm, beautiful day. And I do want to call out the fact that right now, our First Nations people have some of the worst health outcomes in the world. And I no doubt everyone's bound by the same passion of equity, of access. And I think it's a universal declaration of human rights that everyone should be afforded the same healthcare and the same outcomes. So I think that's a challenge for us as well. In addition, we have migrants, asylum seekers, refugees, people who don't have the same opportunities that we may have in this room. So that's the public health challenge. I do want to acknowledge you, as Helen said, taking a couple of hours of your day, and you're all very busy people. And obviously that's because you're passionate about this topic. It's not just for the view and the food. It's also to network, to again, get some good ideas and stoke some creativity about public health. And finally, because I always forget at the end, I do want to thank VHA. It's been an absolute pleasure working with VHA and Helen and Hazel and Hayley. I can't see where you are, but you are in the room somewhere. There you are. But also the Nous team, Holly, Tim, Nick, Sam, Ra, Alan, and there are others. And I believe the idea for this event came from Tim Tucker and previous Deputy CEO of VHA, thinking, let's get our networks together and let's talk about the difficult topics that we're all so passionate about. So thank you again for coming. It'll be a great event. You'll enjoy it, no doubt. And I'm sure you'll all agree, let's release the panel. Let's get them to the stage. Let's warmly welcome them to the stage, please. So, bit of a warning. Before I read out the bios, and after I finish reading the bios, you're all going to think either one of two things. what have I done in my life? And I feel adequately underqualified. Or secondly, I'm going to go do another degree on the weekend. We don't hope you have neither thought. But I very, very excited to have this panel brought together today. We deliberately tried to think of diversity. We've got people from different backgrounds and perspectives. And we've told the panelists to have no restrictions in what they say. Chatham House rules, as Helen said. So it'd be great to hear all their views. So first we've got Nadia, Dr. Nadia Chaves. Nadia is an infectious disease specialist, many hats though, and he's also an Alfred Hospital, Alfred Health physician, works for CoHealth, which is a not-for-profit community provider. Nadia was a key part of the COVID response. In fact, worked at the Department of Health and has a real passion for refugees, for asylum seekers, Indigenous communities as well. So again, wears a lot of hats. Nadia's also been a recipient of the NHMRC Fellowship, has a real passion in translating the latest health advice and promotion to people who don't speak the language or don't speak the health language either. And I think that's a very important part that we can't neglect. Also, a Victorian Refugee Health Fellow, and played a key role in the National Health Assessment for refugees and asylum seekers. And a Fellow of the Royal Australasian College of Physicians. And I'm sorry I'm saying this as well, Nadia, but also a yoga teacher. 500 hours of practice. And you can talk with Nadia about that later. So thank you, Nadia. We also have Professor Anna Peters, Professor of Epidemiology and Equity in Public Health, and the inaugural Director of the Institute for Health Transformation at Deakin University. Anna's very passionate about public health and is especially passionate about equitable and informed decision-making in public health. Is a regular on the conversation in media circles as well, and sits on the Vic Health board. So partly, is she your boss, Sandro? Technically, so you've got to be careful. So Anna is the lead investigator of the NHMRC Centre for Research Excellence in Food Retail Environments for Health, and sits on several national and international policy and research advisory groups, including the World Cancer Research Fund. And also, I think, it goes without saying, very well-deserved member of the Order of Australia as well recently, Anna, so thank you. And last but not least, Dr. Sandro Di Maio, medical doctor, public health advocate, but also the CEO of Vic Health. And can I say, has done so many exciting things at the helm of Vic Health in the last, I think, nearly 5 years. Also in the past, medical officer for non-communicable conditions at WHO, CEO of the EAT Foundation, which is a science-based global platform for food systems transformation, and is a member of the Nutrition Strategy Advisory Board, and in his pro bono work, in his spare time, I don't know where you find it, co-founded NCD Free Global Social Movement, which reached more than 2.5 million people. And also, I think, one of our favourite TV doctors as well. There's a few of them. So again, let's warmly welcome our panel. So the first question, I've told the panel that we're not going to give them too much of a heads up on the question, so we can keep it live and spontaneous. The first question is about what is public health, the definition of it. I'm sure you'd all agree during COVID, people became more aware of public health. Finally, people realised what epidemiologists do, which is a good thing. However, I'd also challenge that public health was more in the minds of infectious diseases, and maybe that's conflated with other components of public health. So to each of you, and maybe I'll start with you, Nadia, what is public health in your terms? Does the community, does government agree with that definition?
Thank you, Paul, and thank you for that very kind introduction. I also want to start by acknowledging that I'm standing on Wurundjeri country in the oldest living continuous culture on earth, and I don't think we can talk about public health in Australia without thinking about the gross inequities that our First Nations peoples face. Public health for me, I guess I'll start with the World Health Organization definition, because it starts with the art and the science of preventing illness, promoting well-being, and making sure that society works together to have good health. But for me, I actually need to think about what wellness means to different people. And it isn't just physical, mental or social. I think in this current context, it's environmental, it's spiritual, it's societal wellness, and it's planetary wellness. So I better probably stop there because I could keep going, but that's kind of my all-encompassing definition. And it's certainly not just about infectious diseases. And I did infectious diseases as a specialty because I thought it was about social determinants. And then I found out it was about infections. And that's why I've moved on and done other things. I still work in infections, but public health is so much more than that.
Great. Thank you. Thanks. And thanks again for the invitation. Really appreciate it. Just warning you all, I've been serially losing my voice over the last 2 weeks. So hopefully I don't do it this morning, but in case I do. Look, I think it's a really important thing to touch on, and I would also like to start by acknowledging the Aboriginal and Torres Strait Islander owners of the land that we're on. And also, I think in the context of public health, just to call out that, you know, we have this once in a generation opportunity this year to vote for a voice for the Aboriginal and Torres Strait Islanders. And I think I would just like to say, you know, in a really respectful way, that public health evidence is very clear that self-determination is a path to positive health outcomes. And I think it's incumbent on us to engage in respectful conversations to try and make sure that we support our Aboriginal and Torres Strait Islander allies in this referendum. And I guess touching more broadly on, you know, the goals of public health, and I agree with Nadia, obviously, the additional things I was going to say were, I think we all agree it's important to improve the health of populations and it's important to address inequities, but I'm not sure we all know what a crisis it is at the moment. And we've touched on some of those elements, such as First Nations health and the environment, but I'm not sure that we're also aware that, you know, for the first time in decades now, life expectancy is in Australia not increasing at the same rate it used to. And in countries like America, life expectancy is actually going backwards. Again, in Australia, for the first time in decades, cardiovascular disease, cancer and dementia mortality rates have gone up in the last few years. This is, you know, really quite profound, I think, and I think it's incumbent on all of us across the health sector to think about how do we start to kind of stem what is a growing public health crisis, let alone the inequities. So again, we know inequities exist, but to call out numbers like Aboriginal and Torres Strait Islanders have 5 times the rate of diabetes. People living in remote areas in Australia have 4 times the rate of diabetes. Like, these are really avoidable health outcomes that you would imagine lots of people of goodwill and high capacity should be able to address, and we haven't addressed that yet. So I think, you know, public health is important. I would say it's actually critical. And then the final thing, I guess, that I would say is in terms of the new public health. I mean, I think the old public health is just as important as it ever was. We really need to lean into understanding the drivers of these public health crises, and they are social determinants of health, but they're also commercial determinants of health. And I think where our thinking is going now is really trying to recognise, you know, there are a number of systems that lead to these outcomes. That's what a wicked problem is. And I think we're realising there's a number of interconnected systems, you know, whether it's the environment or the food system or the way we work or the way we, you know, develop energy or the health system itself. We can all point to areas that probably need improvement. I think what we don't acknowledge so much is those systems are interconnected. And I think, again, as public health leaders, it's really incumbent on us to identify what's our place in those systems, how can we connect across systems, and how can we leverage that to improve the health for all Australians.
I'm not sure I have I'm glad I went last. I'm not sure I have a lot to add. I too would like to just start by acknowledging the Wurundjeri Wurrung owners of the land that we're on here in Naarm, and also reflect on the fact that we stand just a few weeks from such an important question for our nation. Reflect on our role as allies and leaders, and, you know, I kind of humbly share with you, with no meaning beyond it just to be open, that I will be voting yes on October 14. I think it's the right thing to do for our country, but I also believe as a health leader that it will actually bring significant health benefits, not just for First Nations Australians, but as Anna and Nadia have both said, when we address health inequalities, everyone benefits, and I think that it will bring benefits for our entire country. Public health is, you know, it is this kind of tricky, wicked, messy, but really exciting challenge of making collective, wise decisions for a better tomorrow. with an intergenerational, planetary, and kind of equity lens to that decision making. It sounds very jargonistic, but it's fraught, it's complex, it's wicked. Very often it's this mixture of science and art, as Nadia mentioned. And where we stand at the moment, these decisions have never been more urgent. We probably needed to make better decisions 30 or 40 years ago, if we're honest. But, as the saying goes, the second best time to plant a tree, if not 10 years ago, is today. I think we also know that the complexity of these problems, when I wake up and look at the news this morning, things that we accepted as a kind of rational, normal frame of how we see the world, how we approach conversations, how we even approach the challenge itself, let alone approach solving the challenge or having a conversation about the challenge. We seem to have taken a step back in the last months and the last years. So these problems are more urgent than ever. They're over urgent. We have a climate emergency unraveling around us. We are well and truly beyond, 6 of the 9 planetary boundaries. We also know that health inequities have gone backwards. We committed to global goals in 2015. Most of them we've made no progress. Many we've in fact gone in the wrong direction. So there's this urgency, there's this complexity, and then there's this unique and fascinating context. Politically, there are some opportunities, but media and conversations have become far more complex and fraught. The challenges in the next century won't be solved by doctors and by a biomedical approach to public health, as they weren't solved in the last century, although we continue to forget that for some reason. And we also know that, there are multiple converging crises. And so, it would be lovely to be able to stand and say, let's take on one at a time. But actually, the root causes of most of them are shared. The solutions are also shared, which is an opportunity. But it also, again, comes back to that messiness, that complexity, and the truly wicked nature of some of these challenges.
Thank you, Sandro, Anna and Nadia. And looking around the room, there's such a diverse group of people, from CEOs of large hospitals to public health units to community providers, Ambulance Victoria, you name it. So I think hearing all that, there's a challenge. However, there's the right people in the room to act locally, act on the system, and be a collective. So I think it's great, really set the scene nicely, and hopefully that's empowered you. There's some confronting things there too, but we need to also, as health leaders, hear the confronting first before we can move forward. So thank you for starting us off, panelists. I'll now come to you, Anna. I've got a question about measurement. Peter Drucker once said, if you can't measure it, you can't manage it. And given you're the professor on the panel, I'll ask you a professory type of question. And that is, how do we know if we're making a difference? And are we improving, given all the effort, all the investment for decades?
I'll try and give a professory answer. So I think one of the opportunities, one of the reasons I was really excited to come today was because of who's in the room. So I'm really excited to hear later from you in terms of, what are the opportunities you see? You really sit at that intersection, I think, between community, different healthcare providers. So where do you see the opportunities to do that kind of embedded systemic prevention? And one of the reasons that's exciting to me is because I think in terms of your question, the best way to evaluate how we're going is to try and embed measurement wherever we can in the practice change, so that we get quick results and answers, but also that we can communicate outcomes that matter to the rest of the sector, and they can work out, well, that is a good thing from our perspective to implement. So I thought I might just give you a couple of quick examples. One that I know of, that Western Public Health, who I know are here at the moment, have worked on. They really, I think, scanned the sector to look for what are prevention opportunities where we don't have to reinvent the wheel. We might be able to apply something that's useful to our community, and then what can we value add? And so they took a program which happened to come from Deakin called Infant, which is a maternal child prevention program focused on nutrition and activity. And they said, well, we can scale this across our community, so that's one win. But what can we value add is we can translate it into languages that are relevant to our community and then provide that back to other, LGAs, public health units that might want to use it. But we can also measure what are the kind of costs of delivering it, the costs of adapting it, and the outcomes. So we can have some kind of business case for other regions that might want to adapt this or use this approach. And so, our health economics team kind of quickly embedded and in a very non-professory way, which I think is one of the points here. Like, we can't do the old research in the same way we can't do the old public health. We can't do a 5-year trial. And so our health economist actually literally said to me, I really like this messy health economics. And I think we have to learn as academics, how do we provide data rapidly that's meaningful for the people implementing these changes and for those who might want to use it. And I guess just a really quick second one, we did a lot of work a while ago with Alfred Health in terms of shifting their drinks provision and their food provision to be healthier. And what became crystal clear then was public health researchers were generally collecting health outcomes as the measures, but not collecting the outcomes that were relevant to the implementers. And in this case, it was the food managers, the retail managers, who wanted to know what's happening to my profit, what's happening to my customer satisfaction. So again, we quickly adapted our outcome measurement to measure the things that were relevant to the system. So I could go on for hours, obviously, and I won't, but I think the point to make is there is lots of routine data we should be tracking. Some things are getting better, some things aren't. But I think the real opportunity with a group like this is to think about, well, what are the changes we know we want to make and how do we embed measurement/research to rapidly inform whether that's a good thing to continue and expand.
I think that's a very professory answer, and I thank you. So it's about being agile and lean, but also we all know we don't focus just on outputs, but outcomes, but the right outcomes. Sandro, Nadia, anything to add to that response?
I completely agree. And I think one of the challenges for us in the room is, are we measuring the right outcomes for the right people? And I challenge you all to look at the work that you're doing in your own space and make sure that you are measuring outcomes for people who speak a language other than English, as an example. So we know in the Footscray region, 1 in 2 people speak a language other than English at home. But in the Australian population, it's 1 in 5. Could I have a show of hands as to who speaks a language other than English at home in the room? Excellent. Is it 1 in 5? Maybe a bit less. How many people were not born in Australia? Yep, so almost 1 in 2. So it's a great representation in the room. But if you look at what's happening in your own organisations, often the research that's done does actually leave out certain people. I won't ask about socioeconomic background, but we know that people in the lowest socioeconomic quintile have the worst health outcomes, and they're not the decision makers. And so we need to actually, it's not just about cultural diversity, it's about diversity in agency and social capital and connections. And we have to make sure we count these people when we're designing our health outcomes, otherwise they'll not be seen. And I can give examples of where people have been included, but also where people have not been included. And I think COVID showed us that, because I think when the COVID pandemic first came out, we didn't think about, we were like, right, who do we tackle? How do we get these messages out? And a lot of my clients, I work in the West in Kensington, thought that Tom Hanks and Rita were the only ones that got COVID, and that actually only white people got COVID. That was actually a thing. And at CoHealth, well before the public high-rise lockdowns happened, we were trying to race out and make translations, because the ones that were in the public towers were in Russian and Chinese around Flemington, which was not relevant for the community. But COVID's an outcome that, what happened then though was extraordinary and involves many of you in the room, in that despite what that kind of one-size-fits-all approach at a higher level, so many of you got in there and said, right, this is not what our communities are like. How do we change things? And we need to do this not just for COVID. We need to do this for every public health outcome. And I think that's one of the kind of silver linings of COVID. And I had the opportunity to work with Jane Nelson and a number of 5 community health organisations in providing tailor-made vaccine approaches for COVID. But we can do this in other areas too. So like the town hall vaccination clinic, or the ones in the community health service in Meadow Heights, or that community said they wanted, or that there was a gap. Where are the gaps in our other public health outcomes? Who aren't we reaching? Because I think they're disproportionately being affected. And yet I think on the broad base, sometimes it looks like one size fits most will be good enough. I know that in other areas that this has been measured, say mental health, in Victoria, 1 in 5 people who commit suicide are from a culturally and linguistically diverse background, yet a lot of the suicide prevention activities are not actually focused on culturally and linguistically diverse communities, as one kind of example. And things are changing now because that data is being collected. The Australian Institute for Healthcare and Wellbeing did not actually look at cultural diversity, and I'm looking at that as an example, but there's many other intersections. But they didn't look at that according to disease prevention until post-2020. And we know that diabetes affects South Asians at 3 to 4 times the rate. So, you know, we need to look at all the different intersections. Can I give you my little mnemonic for intersections in terms of if you're wondering, well, who am I supposed to be looking at? We need to look at the system, but my little acronym that I think about is Progress Plus, which is their Cochrane equity-focused acronym. And I do it because it's easy to remember. So P is for place, you know, which suburb and which area, and which sort of house do people live in. R is for race or ethnicity. O is for occupation. We know occupation puts you at primary risk of certain health outcomes. G is for gender preference. R is for religion. We know certain religions, if you're a secular in Australia, you kind of fit in on the broad scheme of things. E is, of course, economics. I've forgotten the other S, social capital. Social capital is one of my favourite ones, actually, because it's connection. It's how likely you are to face racism when you walk down the street. It's who you know and whether you went to the right school in terms of whether you get the right job. The other things that come in there, the plus bit is age. We know that our elderly people are some of the most left out in terms of some of our health promotion activities. And why are they? Because we're going to have a crisis in ageing coming up. Distance from the local hospital. So if you're in a regional area in Victoria, you know, your access to healthcare is so much worse. But also in the suburbs that were most affected by some of our COVID cases are also the highest with diabetes and the highest with obesity. And they've got the fewest number of GPs per capita and the fewest number of pharmacists. So we have all this amazing data. But then what we need to think about is how do we collect outcomes and design systems that proportionately affects those that are disproportionately affected. I'm a bit wordy.
No, I think that's great. And mnemonic, I think everyone in health loves a good mnemonic. So some really good...
disabilities in there as well. Sorry, had to remember that.
Thank you, Nadia. Sandro, from a Vic Health perspective, measurement, knowing that you're doing the right thing, what are your views?
Well, I was just going to very quickly, you know, I always believe, it was someone very wise who once said to me, what matters gets measured, what measures get measured gets done. And we kind of know that adage. But as health leaders, I mean, I agree. I don't want to just repeat what everyone else is, what these two esteemed colleagues are saying, but including my boss. No, I joke, but you're all my bosses. I work for the people of Victoria, clearly. So what I would say is that as a leader investing, and for everyone in the room, investing or commissioning or really designing the architecture of evaluation, really thinking carefully about what your decisions tell society, the norm-setting value that it has. So kind of rising above the details of what it is that we're measuring. What does the decision of what you decide to measure and prioritise tell your staff? Incredibly important for culture. Tell the community as a norm setter and as a leader in healthcare, because others will start measuring the same things. They'll align their investments with your measurements. As a funder, they do that. And so I think being really conscious, also being conscious of what needs to be measured at the other end for key constituents, partners, and the people that I work for. I'm joking, but my board, the people of Victoria, and politicians who ultimately, you know, are responsible for the act that enshrines our legislation and therefore our existence. You know, what do I need to make sure I'm communicating, measuring, that is going to prioritise in their minds the things that should be prioritised in line with what I think is important in our strategy, but also is going to give them what they need to continue to support, you know, the work that we're doing, the long-term protection of investment in public health. So I think, you know, really not so much focused on, I agree in terms of what we measure and how we measure, I think reflecting on our roles as architects and designers of that system, the shadow that we cast when we say something's important or isn't, the roll-on effects, as I say, as a funder, it will define then what lots of people do because they try to align with the funding. And I think the other reflection is also take some risk. What we're doing at the moment, how we're measuring progress at the moment, is clearly not working. We've known for eons that prevention is better than cure, but whether it's our economy, whether it's our environment, whether it's our health, whether it's all the different forms of inequality, most of these are going in the wrong direction. So what we're measuring, how we're communicating those measurements is not working. So let's also take some risk and maybe listen a little better to others and go outside the kind of biomedical chamber and measure some things that others are telling us might be important and see where that leads us.
And give those people a voice. If they're in the trenches and they don't have the language
again,
skills.
What gets measured, what matters gets measured, and it goes the same the other way. What's measured matters. So if you're building measurements that are based on voices of the communities that we serve, that shows them that they're important, but it also actually embeds them in the evaluation and gives them power, legitimacy, and a right to be at the table.
Well said. An unplanned question for all three of you, and you have to promise to keep it to 2-3 words. If we did an imaginary straw poll of everyone in the community right now, all 6 million, I think it is, Victorians, and the question was, what does public health mean? What are the 2-3 words that would come to the average person's mind? Anna?
I'll be facetious. I don't know, I think.
Okay. Nadia?
It's funny, I did a straw poll just on my Uber driver today, but it was really interesting because he said, I think junk food. I think we've got to stop junk food because that's going to be it's terrible. And
I got his number. I might give him a call.
He was awesome. And then he said, and vaping.
Oh, well. It was actually me. I'm going to be honest. It was me. I drove Nadia in this morning.
He doubles as an Uber driver. That's right.
No, but it's really interesting and I think if you ask people in different suburbs in Melbourne, they'd say different things actually. And I think that's what's tricky.
Thank you.
I think some people would, COVID's still fresh in our minds. I think people do see it still through that, probably even more so through that infectious disease lens. I think people also often conflate public health for public health care, so the public health system, even people in the medical community, in the health sector. But I think that's the opportunity, and one of the big opportunities that we have at hand at the moment is really making sure that people are, and I think they increasingly are, connecting big existential societal issues with health. Fundamentally, the climate crisis is a health crisis. It will become it is becoming a health system crisis, but it's a health crisis. The cost of living crisis is a health crisis. These are going to show up in the healthcare burden, in the healthcare budget, and most importantly in health and health inequities. I think people are starting to realise that because they're seeing it firsthand, whether it's the effects of heat, air pollution, or the bushfires, whether it's the increasing food costs and people literally can't afford to put good food on the table in one of the richest countries in the world. I think more and more our minds as a community are starting to shift to realise that public health is a systemic societal issue. I don't know if people have conceptualised it fully in that way, but I also believe that most Australians know deep down that something is fundamentally and very seriously wrong. Again, I don't know that they necessarily know what it is or how to solve it. I don't think any of us do. And probably, again, in the context of the last couple of years, they'll be looking to the healthcare community and the medical community to help find a way out of this very serious challenge we find ourselves in.
Thank you all. And notice the academic was the only one who kept it to 2-3 words, but no, jokes aside, I think excellent responses. And I think going back to Anna's point and joining it with what you've said, Sandro, most people don't know. And I agree, as a previous public hospital executive, most people don't know where to start when it comes to public health. And the old saying, if it's everything, it's nothing. if it's hard to capture and define and make tangible, it's nothing. So I think that's another challenge, isn't it? It's the narrative is another way of saying the average person out there, not this room. This room's not the average person out there. What do they think? And it sounds like Uber drivers probably on the money so far.
Can I just challenge that, Paul? Because I spent 10 years trying to, traveling around the world, banging on about this group of diseases called non-communicable diseases, which, as it turns out, people don't need to know the term, this kind of really jargonistic, nerdy term that I was obsessed with. They don't even really need to know, the diseases, because it's very deficit focused and often leads to us pointing the finger at individuals as opposed to the true root cause of this issue, which is this misalignment between profit and prosperity, I believe, fundamentally. But what they do need to know are the solutions. So, we've thought about the social determinants of health and we tried to get everyone to know what that was. Then we had health in all policies and we thought that every minister should be a health minister. I think it's a very arrogant, health-centric way of thinking about the world. I don't need Jim Chalmers to become a health minister. I'm very happy for him just to focus on the economy, but I will be absolutely helping him realise, if I can, that we have no economy without health, not only the planet, but also people. So I think, I don't know if being invisible makes it, that being invisible is actually a problem. I think that we can kind of bake, all of these issues are health issues. We don't need everyone else to necessarily understand their health issues, as long as they understand that the solutions at hand will have co-benefits, or in fact, they don't even need to know that, because the solutions at hand will have such strong co-benefits for health. If we can help them get their solutions across, whether it's, a more equitable taxation system, whether it's addressing renewable energies and the transition to a cleaner economy, whether it's even the housing crisis, I don't need them to know it's a health issue. I don't need them to think about health necessarily, unless it's going to help them to get further faster. I'm going to help them get those policies over the line, because I know that it will have dividends for health. They don't need to know that necessarily. So I just think, we need to make sure that we're, that kind of idea of health in all policies, it doesn't become a bit of a vanity project. Let Jim be the economist and manage the economy, because if that's done well and we can move to a green economy sooner, or if we can embed a wellbeing economy approach, that will have such dividends for health that we will kind of be a co-benefits riding the wave.
And I'll come to it soon. It's the interconnection of the systems, isn't it? That's important too. I will come to, but Anna first, and then I'll go to Nadia.
Just a quick, so I completely agree, obviously, that we want to drive all these things regardless of the sector that's driving it. I guess all I would say is I still think there are measurement issues. Like, I think we have to work out, well, what are we measuring then that makes it a good thing to do for that sector? So I think we need to get more sophisticated there. And I do think, and you touched on it in your first response, I do think maybe it's not about the person on the street, but in terms of where health funding comes from, I think a misunderstanding of public health as public hospitals is really detrimental to funding of prevention and, kind of primary prevention and public health in the community. So I think that is an issue we actually do need to work together on to have a lot more clarity around what specifically might public health look like that you might invest in from a health portfolio that's going to have the long-term benefits.
And like you were saying, Sandra, everyone playing their role for the overall benefit, I think, of society. Thank you both. And the question for you, Nadia, is about the will. There's a will, but what gets in the way is my question to you. You work with a lot of vulnerable communities. So question to you is, what are the big barriers that we need to think about, try to tackle?
Thanks for that question, Paul. I guess I'll start by saying the term vulnerable is not necessarily the term I would use. I think it's systems and societies that put people in a position where they are vulnerable. The people themselves are not. Often people need the equal opportunities to be able to access services. And if our services and systems crush people, they can't actually get up. In terms of barriers, sometimes I think, well, who needs to do what differently in terms of the behaviour change approach? What is it that needs to happen? And I think it does need to be a combination of systems, but also individual agency, but without the system stuff, the barriers are huge. In terms of the different groups, I think intersections are very important to acknowledge. So there aren't lots of different groups. Everyone's got their own. Certain things are cumulative, and it's the systems rather than the individuals. But unless we have good consultation with the different communities, we're never going to know those. And I can't kind of give a broad, these are the barriers, because they are quite unique, depending on, say, for example, asylum seekers. I could use people who are seeking asylum in this country as an example. I worked as a refugee health fellow across Victoria looking at trying to improve the care for people who are seeking asylum and refugees. And to start with, many people couldn't even access any health services, and they were sent bills from hospitals. And so if you're talking about people who are disproportionately getting poor health outcomes, the systems just didn't work for them. Even though our government says we will look after asylum seekers, the translation of that down to the actual emergency department level wasn't happening. But in our society at the moment, accessing a GP costs a lot of money for the average person. So, you know, you could go on about those things.
Yeah, and absolutely. And then people in this room, and there's a lot of people who do manage a very diverse group of the community, but I think intersections is a bit of a theme here because there are such a diverse group in this room. It's how do we work together for the common good. So rather than asking both of you about barriers, it feels like we want to get to the systems approach, which I'll do now. And for those who haven't looked at the Vic Health strategy, the next 10 years, it's quite elegant, by the way, and really a different paradigm, if it's my observation, different paradigm of it's not just about the individual and empowering them, it's also about looking at the different systems. So I won't do it justice, I'll let others talk about it. But my question to you, Sandro, is with that different focus and a really great focus, how does the approach to advocacy, engaging with community, with government change? Give us some examples as to how the approach to getting more investment, because we can all argue there's not enough.
So we have moved to, for the first time, we've embedded a systems-based approach, and I should acknowledge Anna's leadership in our board. Obviously, strategy is, very much driven by and with the board. So, this sees us really call out for the first time long-term aspirations, health, equity, and economy. So economy is return on investment, sharpening the tool, growing the tool shed, to make sure that we're best positioned to be able to tell that compelling story of the return on investment that we know prevention has, $14.50 or whatever it was per dollar invested, CSIRO recently thought. Then we've got three systems, so food, commercial and economic, and the built environment, the built sort of system. Obviously, there's huge overlap between those three. Housing, quality, affordability, access is at the nexus of all three. Digital marketing or food environments in the physical space is again at the nexus of all three. And then we have three cross-cutting equity lenses. So intergenerational wellbeing, the idea of tomorrow's Victoria in decisions we make today, climate justice and climate action, and also self-determination and centering, the idea that when you actually involve people in the decisions that affect their lives, we get much better outcomes. We usually make better decisions, get better value for money, less waste, and get further faster. What was the question, Paul?
How is your approach to advocacy, getting more investment from government changed as a result?
Yeah, I mean, look, I think it's more of an authorising environment for, again, it's kind of that question around, it sends, the strategy is about giving my team a framework, reflecting the fact that we're a funder and a leader, so it will influence the framework others use. So we're already seeing local governments, other jurisdictions around Australia, even internationally, using the framework of the systems approach that we've developed. It starts to kind of change the language and the norms that we all use and think about. But, the reality is that the work had already begun 2 or 3 years ago. So, making sure that we as a workforce reflect the diversity of the communities that we serve, making sure that we're involving and regularly turning up and working with communities across Victoria, again, building our ideas around the principle that communities know their challenges and solutions better than we do. Our job is not to tell them what to do, it's to give them resources, the access, the convening power that we, and the privilege ultimately that we, right or wrong, have. And from an advocacy perspective, it makes, it does change the way we do things. So, we now have more active partnerships with Infrastructure Victoria. So Jonathan Spears and the team, turns out we've been swimming, in parallel lanes of the pool for a decade, but never bothered to look over the divider and go, hang on a second, you're talking about health in planning. We're talking about health in planning. Why don't we work together? Or Climate and Health Alliance, again, parallel lanes, very similar issues. So it allows us probably to think slightly differently about who we partner with, where we invest, how we partner. And it also allows us, of course, to have really important, much more connected conversations. So rather than focusing on, the kind of, we still focus on very pointed, granular policies, but we're also very engaged in, two federal conversations, one around the wellbeing economy, really rethinking the way that we actually approach our economy and how it relates to health and wellbeing. And the other is, of course, I think the biggest opportunity, the most urgent opportunity for our country is the promise to establish a Centres for Disease Control and Prevention, and making sure that actually that, the governance, the architecture, the funding, the authorising environment, and all the lessons we learnt from the government establishing Vic Health in the late 80s that have meant that we have a protected, legislated source of funding and support that have benefited so many, including myself, over decades, that we don't miss the opportunity to have that same opportunity, to have that same architecture at the federal level. So yeah, it's changed, given us the kind of the frame and the authorising environment to to think more broadly about where we work and who we work with, but still making sure that the public understand why we're working in those spaces, that they're not thinking, gosh, what's Vic Health doing working with Jonathan and the Infrastructure Victoria team? Shouldn't they be working on health issues? Because we have a really clear articulation of actually, how we plan our cities ultimately has a massive impact on the health outcomes that we achieve as a community.
And it's taken the community on the ride for that paradigm shift, or the different way of looking at it. I'm glad you brought up the ACDC. Great name, by the way. I was going to ask you about that, but definitely a massive opportunity to do it the right way. And finally, Anna, in terms of the systems lens, the new approach, what was your vision when you first started having that conversation?
Can I answer a different question?
I did give you permission to do that earlier, so yes.
I guess the thing I wanted to say about the systems approach, I wanted to say a couple of things. One is perhaps to make it, paint a picture. So from the sort of food system perspective where I do a lot of work, I think one way to kind of make it clear that how important it is that we understand it and then find our role in it is, if we have campaigns telling our children how to eat well, they go to school, they're taught how to eat well, but then every environment that they're in, including their phones, pushes really heavily unhealthy options, you can just see that that's going to fail. And so I suppose it's thinking about, because I think the narrative often that's tricky is, well, it's just this one place, or it's just this one treat, or it's just this one occasion. But if you think about the system, you realise that all those occasions add up to what makes it so difficult for that child to enact that kind of educational prompting. And the other thing I wanted to say, because I think systems can feel really overwhelming, and okay, fine, it's a big system and it's a wicked problem. What do I do, and what do I do differently? And so I think, I'm not going to talk for hours on it, but I think that would be a really useful thing to talk about, because I think it's more enabling to think about, okay, well, what is my role in that system? And I think, all the leaders here, one of the really important moments in time, I think, is that trust in every institution is just crumbling right now, like every poll, but not in the medical profession or the healthcare profession. And so I think it, sorry to put so much on your shoulders, but I think it really is a moment in time in which, the healthcare professions can be those trusted people around how can we make this system change. And I think that is about, the evidence is around collective impact models. It's what are we going to join up on? What is our kind of shared goal? But then what's our individual places in that system and in those shared goals, so that we're not overwhelmed by thinking we have to change this whole system. So I might leave it there, but I think there's a bucket load to say about that.
Yeah, no, fantastic, Anna. Of course you can.
I just wanted to add a little example that reflects on both what you've been both saying. Is anyone from Moonee Valley City Council here? No. So the Flemington Towers have recently had an amazing hub co-created with local residents by Moonee Valley City Council. And it basically it's the vision that you're describing in terms of community. I think I just went to the opening. I was so impressed because it's that vision of that kind of a place for connection and community, but also for education and health education. It's got a native garden with a food garden. It's got a space for community to come together and have celebrations, but also have education sessions and health information and mothers groups. And it's got a basketball court, and it's got a kitchen where people can cook healthy meals, and it's got a podcasting station so people can get that messages out in languages to their own communities, and it's all in the Flemington Towers region, and it's spectacular. But it really summed up for me when I went what I think wellness should be and what it should look like. And it's a partnership between local government, and it's got some government funding, but it's got community actually saying what it is they think they'd like, and trying to make it a reality. So I'm looking forward to seeing how that space goes, and I might be teaching some yoga there too. But from when the women said, "Oh, I'd really love it," but it's what if people identify things that are going to help facilitate that healthy lifestyle, and from a really practical point of view, sometimes people we may think we know what people should do for their healthy lifestyle, but if we actually empower people and communities to understand what's out there, and what they can tap into, that's what makes it real. And in that particular area, I've been working there for 10 years, and I often speak to my I look after work with a lot of women of migrant backgrounds, and when I talk to them about exercise, a lot of them are scared to go out, wearing a hijab, walking the streets. They get yelled at by people. They don't feel safe exercising. So if you look at that from such a practical, how do we create societies that make it a safe place to be? Because how can we say, so that just it's those little things that, we may not think about, but if you ask people, what are the barriers for you to exercising or healthy eating?
And no amount of education on how to exercise is going to help that woman. But I also go back to the earlier example, great exemplar of how all those systems can connect from a housing, food, promotion point of view. Thank you so much. We are pressed for time, but I do want to take one or two questions from the audience. So I think you'd agree the panel, I let it go a little bit longer. It was a fantastic conversation. So one or two questions from the audience, and I'll give you three a heads up. At the end of the questions, a 1 minute take-home message, 1 minute. Message in a bottle, but a biodegradable recycled bottle, of course. 1 minute for the audience, especially given who we have in the room. But before we do that, just one or two questions from the audience. Yes, thank you. We'll bring you a roving mic. Maybe state your name and where you're from, please.
Tony McBride, I'm chair of Your Community Health. It's not as if we're babes in the wood in this area. We've been world leaders in addressing smoking, road accidents, and HIV/AIDS. And yet, it seems to me, we haven't quite translated that fantastic success into other areas. We've struggled to so I'm interested in what you think are the sort of nuggets of those successes that we should be trying to include in our future approaches.
Yeah, no, absolutely. And I have the pleasure of having Nicola Roxon as my chair. So whenever I need a reminder that change is possible, and usually the reminder is her telling me change is possible, and get on with it. So I think that when we look at Mexico and the sugar tax, for example, and the analysis that's been done there, kind of what was the magic sauce in the political economy that allowed them to get that over the line, there are three things that emerge. The first is a really organised civil society and sort of system. So I think there's work we can do, and it's great, conversations like today, making sure that we're all on the same page. There's nothing a minister hates worse than, 10 different people from the public health community saying that 10 different things are the priority. And even worse, if you say, not only is my priority the right priority, but that guy's an idiot. and that happens so often. And I think the more that we can get on the same page and really be very clear on what are the one or two priorities, because there is a policy window opening. I'm very confident of that at the federal level. The next 5 years should be the opportunity to get things done, whatever persuasion of government is in, and the electorate wants it. So I think getting more organised. The second is then there needs to be really strong, clear leadership in politics. And, again, we've touched on that. I believe, not relating to my political persuasions, but I do believe that those opportunities are there and will be there to do something bold and world first in the spaces that we're talking about today. And the third, and some of them are already there, again, wellbeing economy and the CDC. I don't think people understand how critically massive those two opportunities are to do something that is long-term, systems-based, really disruptive, but the opportunities are not being fully leveraged at the moment on a number of fronts for a number of reasons. And the third is then making sure that we have some resources in the system for the advocacy and for the efforts themselves. So in the Mexico example, it came from Bloomberg Philanthropy. It was very strategic and very organised advertising campaigns, those sorts of things. And I think we probably need to be, once we're all on the same page and we decide what the critical priorities are, we possibly need to be, better at accessing resources specifically around the government relations and sort of advocacy work. But e-cigarettes, again, not on the agenda 12 months ago. Within 6 months, Mark Butler announced world first, very, very significant legislation. We're now, in the kind of deep battle of making sure that legislation is protected and gets to Parliament and gets passed. Not going to be easy, but, we're working to make sure that happens. And there has been a national community of experts. Unlike a lot of other jurisdictions, everyone's largely on the same page in the public health community. You've got a government who wants to do something, and you've got an electorate who overwhelmingly wants action to happen, and sooner the better. That's a perfect example of, even in the last 12 months, where something very significant has been able to be achieved by the public health community here in Australia.
Can I just add quickly? Is that all
Sure.
right? What I would add to that is also, I think, in all the areas that you pointed at, we know that you need to have a series of things, like you need to have individual education, you need to have local community action, you need to have regulatory policy. So all those things have to, and then get the industry on board to make their changes, whether that's through regulation. The only thing I would say, though, is that all those examples are less complex systems than mental health, obesity and sustainability. And I think that's one of our current challenges. I'm not, like, they were really hard to do, so I'm not saying they weren't, but these are multifaceted now with lots of different drivers that evolve over time and intersect. And so I think that's why we need a much more joined up systemic response to drive the advocacy that Sandra is talking about.
Thank you, Anna. Thank you, Sandro. We do have time for one more question. I think, Rachel, you had your hand up first, and I see other hands, but don't worry. Soon we're going to have a small table discussion where you'll have lots of time to vent your spleen and ask lots of questions. So, Rachel.
Thanks, Paul. I think I'm just going to pick up on something Anna's just said about industry. I'm aware that everybody in the room, it's a bit like preaching to the converted. Industry is part of the problem, but I think in some situations can be part of the solution. You've demonstrated that, Anna, with your own work with the retail industry. But how do we, regulations or not, how do we bring them into the conversation? Because they are a big part of the systems that we're going to have to change. And being a mum of 2 young kids, I'm very aware that they're flogged unhealthy advertising left, right, and centre. And so, how do we actually bring them on board? What are the obstacles for them to overcome to make our place a little bit healthier?
Yeah, I can start that. I think you're spot on, and I think it's part of it is thinking about the lines of conflict of interest and where can you engage with industry and where perhaps do they have to stay out of policy decision making would be the main line, I think. But in terms of finding solutions, once the policy targets are set, I think you need to work with industry to find the solutions because they're the experts, whether it's, in sort of energy or in food or in, phones. And I think that part of it is looking for where can there be win-wins. So we found in some of the kind of community-based food retail, we could find win-wins, and then it was there, they were keen to shift, and they've shifted, and that's sustained. And where are there really not win-wins? Like, where does it seem like no matter what, it's going to be a loss for the industry? And then I think you need, strong government regulation and targets, and then they see that as the incentive.
Great, thank you, Anna. So again, 1 minute message in a bottle. Again, think about the audience. We have lots of leaders from a diverse slice of the sector. So maybe starting with you, Nadia, 1 minute message.
Well, I guess I want to say thank you for coming, and thank you for the work that you all do in your spaces. I don't think you appreciate really what an amazing health system we have in Australia. And overall, we have such a great system that we can work within. And I think now we've got the opportunity to go for those next steps and make sure that we're caring for all sectors of the community, and make sure that you put things in your own organisations that sustain this message and connect with the systems. And maybe this is a good opportunity to make sure you actually are all on the same page about these things as well. So thank you.
Thanks, Nadia. Anna.
Yeah, thanks very much. As I said before, I guess what I was going to say, but I've already said it, is I think the trust thing is really pivotal. I think, you are one of the few sectors at the moment which really has strong community trust. So I would think about that a lot and what you can do with that without adding to your own workforce burdens. And I suppose the two areas I was thinking are kind of feasible to look at. One is looking at, how health promoting are your own organisations? Are there opportunities for change there? We do tobacco control really well. I think we can do lots better, obviously, in terms of the food that we provide, the extent to which our organisations are sustainable. And I think where you think that's outside the remit of your organisation, then there's a chance to join up and think about, well, who needs to be active to help our own organisations to model health promotion really well. And then I think the second one is that question of the system, so that it doesn't become overwhelming. Is that something where you can collectively agree on some goals, work out different points of intersection, who does what, how do we share what we've learnt? I think we're really bad at reinventing the wheel. So really thinking about, for these big complex issues, how do we kind of lean into the collective wisdom of this group?
Thank you.
Yeah,
Sandra.
mine's very similar. Keep turning up to things like this, engaging, building the strength of collaboration. We go further when we go together. The second is, I think, really reflecting on our power and privilege that we hold. As Anna said, maybe every generation thinks that we stand at a moment in time where there's kind of a diverging road in front of us, and there's one blue pill and one red pill, and we kind of, want to maybe champion one path. But I do believe that we stand at a kind of really, really frightening but exciting and important divergent fork in the road, and we need to reflect on what role we want to have and we can have as health leaders, and we do have, whether we like it or not. And I think the third is, again, I don't want to sound like a broken record, but a lot of the problems stem from the fact that we don't have protected, empowered, resourced architecture and governance for prevention at the federal level that continues to beat this drum, as I think Vic Health's done. And I've only been in the role 4 years, so I'm not reflecting on me. I'm reflecting on the organisation, the institution that's benefited so many in this room and across the ecosystem, as well as Victoria. If we could have something like that at the federal level, and it not just the CDC, not just become another infectious disease body, that would be something that will give dividends for decades. It will be protected. It won't be able to be wiped out by a future government unless the Parliament all decide to vote to wipe it out. And they can get on then with actually looking at the long-term systemic deep structural issues that affect health and well-being for Australians. So I think that's the big issue that everyone should read up about, reflect on, and consider, having a position about.
Great, Sandra. I agree. Lots of opportunities there. Really well said, very articulate as always, and some great messages for the audience. So before I ask you to thank the panelists, we'll ask you to look for a chair. I have cited at least 3 spare chairs. You'll join one of the tables, and I'll hand over in a moment to my colleague Tim Tucker, who'll take you through the small group facilitation. But firstly, please join me in thanking the lovely and very fascinating panel for the discussion.